how to make those decisions. What I have used is how much damage they have already, like how much room for error do I have here? Somebody who has quite limited disease, maybe 1 or 2 small vessels with no significant ischemia. Maybe there's a little bit more wiggle room for error if I get it wrong and something does progress, where somebody who already has, significant stenosis, 2 or 3 of the arteries going to their brain, that person I am probably going to image every year because there's no real room for error.
That's Dr. Alison Clifford. She is a rheumatologist and associate professor in the Faculty of Medicine at the University of Alberta. She has a research and clinical focus on vasculitis, particularly giant cell arteritis, and she is an associate member of CanVasc. We're very happy to have her as our guest to talk vasculitis on this episode of Around the Room, which we're recording in person at the CRA's 2025 Annual Scientific Meeting in Calgary. I'm Daniel Ennis, and a warm welcome to my fabulous co-host, Dr. Janet Pope. How are you?
Pretty darn good. And you?
I'm pretty good as well. Thanks. So let's get to our guest, Dr. Alison Clifford. Welcome to Around the Room.
Oh, thanks so much for having me.
That is our pleasure. You're a big get for the podcast, so thank you for coming on. And it's nice to see you in person.
Yeah, lovely to be here.
So you have a particular interest in vasculitis and giant cell arteritis. I had a chance to look at some of your research work here at the conference, but I was hoping that you could tell us a little bit about what you're working on.
We like looking at large vessel vasculitis. This is still a group of patients that has generally been understudied. We were doing a couple different studies. One was sort of looking at our referral and triage process and how we're doing with that. One of the other projects that we just finished up was sort of looking at new radio tracers to investigate large vessel vasculitis.
What's the goal with the new radio tracer? What are you trying to get out of it that FDG doesn't quite get at?
Yeah. So, I think we're very lucky where we are. We have really excellent FDG access. So we do have good access to that currently. The ongoing issue is the glucocorticoid use. And we sort of know that within 3 days, an FDG PET is really good. But beyond 3 days of prednisone use, it becomes less clear. And even with good access, it's still really hard to get someone scanned within 3 days, I think. So we were trying to look for a new tracer that would maybe be either more specific to the pathogenesis of GCA or that would be less likely to be influenced by glucocorticoids. That was the goal.
So I have a question about this. So when you're actually thinking of imaging, are you doing it, so that's kind of for following,
Mhm.
are you doing it for both diagnosis and following the patient to kind of know how much do we turn down the dial and dampen it? Because it does seem like PET, at least in diseases like Takayasu's of large vessel, that it kind of smolders along. And some of the GCA, that's aortitis, seems to also be positive when inflammatory markers would really fool you because they look normal.
Yeah, I think that's definitely something that we see. With the follow-up, are you meaning like in the context of the research or?
I think the follow-up, though, because eventually a new radio tracer will end up in the clinic, we hope, right? Yeah. If it performs well, and we'd love it to be inexpensive and safe and all that jazz. But I just find that the more I look, the more I find that the disease is active, not highly active, that we usually have a clinical suspicion, but smoldering along, and I don't think we know what to do with it.
Yeah, I agree. I think this is a huge area of uncertainty. It's true. I think there's no good answer yet as to how we should follow people with PET or FDG PET in particular. It's true, sometimes I do as well. I think the literature is really mixed. I think what we tend to see is that it's very uncommon that the disease completely goes into remission radiographically, but it often improves or stays stable. And there are still a lot of questions around what does that mean, that persistent FDG uptake? Is it actually vasculitis that we are not treating, or is it, vessel wall remodeling? Because this is a glucose-based tracer and it's maybe not specific enough to the true pathogenesis. I think those are all really good questions that we don't know yet. Yeah.
It's sort of in the context of like the ascendance of ultrasound in diagnosis and more research evolving on like following GCA in particular. Where do you kind of in your clinical practice, or where do you think PET kind of fits into the algorithm for diagnosis and follow-up? I know that's sort of riffing on Janet's question.
You mean sort of PET versus ultrasounds?
Yeah.
How do we choose?
Yeah, exactly. How do you choose?
I like both.
Okay.
I think like both is the dream. And obviously every center will maybe have access to one versus the other. Probably not every center is going to have good access to both. I honestly think whichever test you have the best access to is the right one to go for, because all of the tests are time sensitive. And what I like to do, I think we need a cranial assessment and we need an extravascular assessment, extra cranial.
Right. And should we be doing that somewhat routinely? I'll call it now in expert centers with GCA expertise or vasculitis interest. Should they be doing it routinely so that we're not really surprised? Because by the time we have a blood pressure difference, say, arm to arm, it's a little bit late.
Yeah, I mean, I think so. I mean, do you need large vessel imaging right up front in everybody? Maybe not, but should we think about getting it at some point early in the course? I think so, because you're right. Later on, a year or 2 or 5 years later, if you have your first imaging at that point, it's very unclear when that disease developed. So I think the more complete picture you get up front, the easier your job is going to be following them over time. So yeah, and be that with, it doesn't have to be PET, up front. I think CT angiogram is also a very reasonable option for your large vessel anatomy. It's going to get
MR angio, what would you think of that?
MR angio, yeah, great too, I think. I mean, I really think each of those modalities shows very similar kinds of findings. So whichever one you have best access to, I think is honestly a very...
And the radiology experience.
And the experience to interpret it. That is probably like the number one, agree, most important thing.
Something that like has come up in reading around PET is that it sort of is its value in identifying other diseases at play, like finding actually someone has an undiagnosed lung cancer, or it's not GCA, like if you're working up an older person with fever of unknown origin or PMR-like symptoms, which is like a pretty non-specific pattern, honestly, or I think so. And PET can kind of quickly get you to the answer of what else it could be, if not GCA. So you might diagnose GCA, but you also might find pancreatic head tumor. And so there's a kind of a broader... It kind of goes a little bit wider with the diagnostics. I'm curious, like in your clinic, are you picking up a lot of non-GCA disease of relevance? So hopefully we're not picking up random lung nodules that no one ever needed to know about. But I am curious if, you're making some non-GCA diagnoses that maybe it would have taken us ages to find if we just did, clinical diagnosis, ultrasound, this and that.
I think that's true. And it's one of the useful and also challenging things about PET. And I always talk to the patients about that when we're going to get it, that there's at least some chance we're going to find something we didn't expect to find, because it is a test that was developed for cancer screening, right, or cancer diagnosis. And so it's true. It's not infrequent, I would say, that the PET may lead to subsequent tests. And sometimes very important ones, and sometimes some incidental things that have resulted in incidental illness. Mm-hmm.
One study that has always been stuck in my head is PET scans in patients with clinical diagnosis of PMR. And so this is where PET almost it worries me, and I'm hoping you can kind of comfort me a little bit. In clinical cases of PMR, PET scans can be positive, 50 to 80, PET can be positive in such a high percent that was never clinical aortitis, though, clinical aortitis is often hidden behind other clinical features. But, just because we find aortitis doesn't mean they truly have what we're worried about as giant cell arteritis. Like how is it giant cell arteritis, or is it PMR with a little bit of action in the aorta? Are these, distinct entities truly, or is it such spectrum?
And will it affect our treatment? The glucocorticoids or steroid-sparing drugs are going to be very different in dosing and the drugs you'd use.
So do we kind of confirm, but do we classify, and I don't want to say overclassify, but do we kind of tend to classify people as GCA just because we find some light up in the aorta? Or is that the correct classification? They do have GCA and they need steroids and DMARS or Actemra up front, or is this more PMR and they need just prednisone monotherapy? I'm not sure how your center treats, but can you kind of work me through how you distinguish
Yeah,
those?
that's a challenging area. I think this is, outside of the realm of evidence, for sure. There is no good evidence to answer this question that I know of, but I can tell you sort of my general feelings about it, which I agree. If we, and there's different ways these PMR studies were done, and I think that's the really challenging thing. There are some studies where they've had everyone with what appeared to be isolated PMR, right? And most of the data, when you look at isolated clinical PMR, seems to me that about 30% of those patients probably have at least some signs of underlying GCA, right? Whether they have had temporary ultrasounds or a PET scan or even a temporary biopsy. There's a couple of those studies too.
Right.
But it's sort of around that 20 to 30% of what appears to be clinically isolated PMR maybe have some signs of actual large vessel vasculitis. And that number feels true clinically because we know about 20, 30% of PMR eventually develop symptoms of GCA. So in my practice, I think, I agree with you. This is a really challenging area. I don't PET scan routinely people who have isolated PMR symptoms, but I will sometimes do a PET scan on what I would consider more the atypical PMR patient. So someone who's a little bit more refractory to glucocorticoids or having a hard time tapering, somebody who doesn't respond to that 20 milligram dose, people with persistently high inflammatory markers that aren't coming down as you would expect. There's some evidence, especially around thigh pain, that thigh pain in the PMR patient that's persistent or claudication-like. I think there's a lot of subclinical femoral artery involvement in this disease. So those kinds of patients I will PET scan. And honestly, if I found, or when I find, what would be convincing aortitis in a PMR. And obviously very important, like you said, Jenna, right, to review the imaging, with your nuclear medicine physicians, make sure that they agree this looks convincing, like the right pattern and the right feel for an aortitis. I do tend to mentally switch my thoughts to this is probably a GCA patient. And treat as such. Is that right or wrong? I don't think we have great evidence.
Right. And Daniel, is that what you do?
We don't routinely use PET just because of access. Like it's primarily used for malignancy and not a knock, but like I think our nuclear medicine physicians are more trained on kind of assessment of cancer rather than aortitis, and so we kind of use it sparingly in people either where we're like we really cannot tell if the aorta is the source of ongoing inflammation. We're having a really hard trouble determining remission. And then sometimes for diagnosis in people with really complicated disease. So we use it sparingly. I do find it largely to be helpful when kind of deployed in those settings. There's kind of a group of patients that we are going to get to where it's kind of the opposite. The clinical suspicion isn't that they have GCA, but they got a PET scan for a malignancy. Maybe they're on a checkpoint inhibitor or not. And they come to you having had a PET scan through our cancer agency and they say they have aortitis. What do you want to do about it? That is an interesting consult. And it does strike me that there probably is a group of people who have some degree of inflammation of the aorta, and it is not ultimately clinically relevant. It would be hard to tell who that is up front. So I certainly...
Right. So I think even walking us through a consult like that, sometimes they're actually found they're dissecting. So nothing to do with cancer. And you go, well, that's probably relevant now. And so particularly for the listeners, how would you work up, we'll call it symptomatic or asymptomatic aortitis, but it seems isolated? What's your differential? What should be ruled out? Because there's some common things that common from 200 years ago and 100 years ago, not so common now, and then some rarer things. So how do you sort of go about it's our problem in the end, rheumatology versus other infectious disease, et cetera?
That's a big question. And there's a big differential.
Yeah.
There's a big differential. And I actually think the first point, whether they're symptomatic or asymptomatic, that's a huge branching point in my mind, right? If we think about the asymptomatic person or the incidentally found, then always my next question is, how was it found? Was it found radiographically or was it found on the tissue? Because same thing, that will very much change the approach sometimes. It doesn't change the differential necessarily, but sometimes the tissue can give you a really nice clue as to what thing you're most worried about. In terms of the overarching differential, we think about like our primary systemic large vessel vasculitis, right? Like GCA would be our most common for sure, and Takayasu's obviously in a younger person. I think about almost every other systemic autoimmune rheumatic disease. So depending on the pattern of involvement in the aorta, you can sometimes get some clues. But rheumatoid, right, and spondyloarthritis, of course, lupus, are all going to do this as well. You can think about weird and wonderful things like sarcoidosis or IgG4. Sometimes the tissue will give you a really nice IgG4 hint. You have to think about infections, because infections we would treat completely differently, and obviously probably not us. But as you mentioned, syphilis, TB, bacterial infections too, more typical bacterial, although usually that person will be very sick, which can be helpful. And then Dan, you also mentioned like a really other important category, which is drug-induced. I think checkpoint inhibitors for sure. This is a well-reported phenomenon now, and also GCSF has been reported pretty clearly as well. So there's a big differential. And then, once you've gone through your whole list, there is an entity of isolated aortitis, right? Which is really a diagnosis of exclusion. So I think the mandate is still on us to think about most of these categories. And obviously it involves a history and a really good physical exam and usually a significant amount of blood work. And then really good imaging. So depending if this was a radiographic diagnosis or especially if it wasn't a radiographic diagnosis, essential, I think, to have a good picture of all of those big blood vessels. So the whole aorta and all the medium branch vessels, because you want to figure out, is it one place or is it lots of places? And that will really help guide you.
That's a really helpful approach. That's a really broad, right? Like it's a really broad differential. So it covers a lot of territory and covers a lot of different specialties. And just thinking back over like CRA meetings from the past, just thinking over CRA meetings from the past, like a lot of the interesting, maybe they're the ones I find interesting, the case reports that residents bring. There's a lot of aortitis, and I can recall posters on TB or atypical mycobacterial infections, Whipple's, some syphilis, salmonella, like certainly other bacterial infection, right? Like wild presentations of diseases. And like now I just sort of store them in the back of my head every time I see an aortitis. I'm like, Whipple's, okay. Like, I mean,
The one Whipple's, right? You see in the aorta, might be.
I mean, right. Any aortitis I see could be the one Whipple's that I ever see. So like, it really isn't as easy as like, oh, you have aortitis. Oh, you have GCA. That is sort of like the hunt begins then for the underlying disease. And
it's very tough to know depending on the imaging, because a lot of it would be traditional imaging. They've had a CT or CT angio for a totally different reason, maybe a valve or something.
Yeah.
And they find it, or they've had an MRI, MRA, usually a PET scan only, I guess, if it's sort of a malignancy they're looking for. They've already diagnosed a malignancy and they're staging it. But I also find it's really tough to know, is this even burnt out? Did this happen 25 years ago and we'll never find the pathology? And that's where I would wonder if a PET scan to really look at, is it metabolically active anymore? Because we do sometimes see those. They're rare, but I would say we get one consult in our unit every year or two that it's like we have no idea, but it looks like it's scarred up and something happened a long time ago.
No, same for us. Definitely like really normal inflammatory markers. I think PET does have some utility there. It's obviously not a perfect test either, but if the PET also looks very quiet, it's very reassuring. This was like the old problem. Maybe there's no value to prednisone anymore and only harm.
In our centre, we've kind of developed a relationship with kind of a CT angio or like the angio radiologists. So we do rounds that I find particularly helpful because radiology and pathology, these are not yes, no, like they are, there's an art to it as well. And so talking over cases with a good radiologist who has an interest and some skill in reading the imaging is really helpful, because I think maybe if they're just whipping through a CTA or a PET and, it looks like it could be vasculitis, well, it's kind of their job to tell you that it could be vasculitis, whereas that's not what you wanted to hear.
We want the pretest likelihood is medium, make it higher or lower,
Right. Like it is true. Like all these tests do like there's a pre-test and post-test probability, yeah, even for their opinion. And so like talking to them in person, I find like makes a difference and also teaches me stuff because when they're like, oh, this is like classic athera. This is not inflammatory arteritis. This is inflammatory atherosclerosis, or this is just burnt out vasculitis, or this is just athero, and it's an overcall. Watching them walk through that and like explaining to me why, how did you figure that out so quickly? Or, oh, there is some FMD in the renal arteries here, and they have burnt out aortitis. They have both, and you're like, huh, okay, good. But I feel like I learn a lot just by listening to their expertise. Hopefully, they also kind of get something out of it too. But I presume you also have kind of a PET or CT people that you trust.
Yeah, I 100% agree. I think the discussion together has to happen because we each bring a piece of the assessment, right? Like the imaging is one piece, and then we sort of bring the clinical story and the exam, and the two have to go together. I feel just like you do. I think especially if your diagnosis hinges on an imaging test, you absolutely must talk to the radiologist and be really sure that you're both very happy that it is definitely a rock solid diagnosis.
And people don't want to go in and biopsy a chunk of an aortic arch or a distal to that, a medium vessel. Nobody's too keen if you talk to the vascular people. So I think it's tough. Have you seen any of these syndromes that can run in families that can give, I guess, multiple stenoses and inflammation? Because it seems like about every 2 or 3 years, there's a new description of something. They're usually younger. Our index of suspicion isn't high, and something happens, like their pulses in one arm or whatever. So that Maya or whatever. There's a lot of different things that usually the trainees tell me are on the different arch. So because they've read, they know the rare bird, but they don't know the sparrow.
Yeah, totally. Yeah. I don't have a lot of genetically associated vasculitis that I have detected, but you're right. It could be that I am missing them. I have seen some moya, which I sort of consider more on like the vasculopathy side, and often a radiographic diagnosis. And again, with a really good review of those images to make sure everyone is happy. But I haven't seen a lot of.
I mean, some of it is that PAN in young kids, like our young people, family history maybe, but because the odd time we'll see it, and I forget what gene it is. I usually have to look it up and then see, can we even order it? And if it's going to take 2 years, is that helpful or not? Right. And then we're kind of stuck with what do we do about it?
Yeah,
It says arteritis.
Right, for sure.
Exactly. We do have access to the testing for that, like adenosine deaminase deficiency, but I haven't picked up any in my practice.
Well, I think it's pretty rare.
I think like there was at the ANCA conference in Dublin, I think there was I believe it was a poster. I can't quite remember, but they were saying of like their PAN cohort, it turned out like 10% had tested positive, but PAN's really
Rare.
It's really rare and
Diagnosis of exclusion as well, right?
yeah, often, and so it's gonna take me a while before I catch one or miss one. Like it's just gonna take a long time for me to build up that many PAN cases. To that end, like this is not aortitis specifically, but the vasculopathies is a group of disorders that I find can be particularly problematic for me as a rheumatologist because our training in aortitis and vasculitis is limited just because it's way rarer than a lot of the other like diseases that we have to learn how to treat as rheumatologists. So maybe leaving training, I hadn't seen a ton of it, but when you get cases like renal artery dissection, and there's some perivascular inflammation that they got on the CT, or they dissected a random their celiac artery.
Absolutely.
Right. These are not these are not uncommon consults now that I'm like working in vasculitis, and they cause me sort of the most distress because it often is a chicken and egg thing, right? So dissection I find to be not a common presentation for most of our inflammatory aortitis or medium vessel vasculitis. So that they're coming with dissection in the first place is weird. If they had no prodrome and they just, boom, dissected an artery, I think that I'm going to need a lot of convincing that that's a true vasculitis.
Before we trigger any
Totally.
treatment. Yes.
And then, of course, like not unsurprisingly, they have some elevated inflammatory marker and perivascular inflammation. When they see an emerge radiologist and they read that CT, they are likely to call that as like, this could be vasculitis with dissection, as opposed to this is dissection and that's just what a dissection looks like. But then the case often gets kicked to us to say, well, do they have an autoimmune disease? And I am curious, I'm sure that you've seen cases like that. I'm very curious how you kind of work through those cases.
Yeah, I agree. This is stressful. We get them too, for sure. And I think, it's true. It could be a vasculitis, but the emphasis is on could. Right? And so I agree. I feel like the history and the pattern of the imaging are often the most important and telling. So obviously, again, same kind of principle as the isolated aortitis consult, the history to look for any of the other features that feels, like a systemic rheumatic disease. But often, more times than not, I find it is often a very sudden onset history, right? Like kaboom, abdominal pain that brought me in. And then there's this dissection, in which case then I find the imaging honestly most helpful. And similar to how I handle the aortitis kind of patient, I have a similar feeling about these ones. I like to get imaging of all of the rest of the blood vessels.
Yeah.
So often we will have, I feel like it is usually mostly mesenteric vessels when this consult comes around. I like to make sure we also have the whole thoracic aorta and all the big branch vessels. And it's true, to have an isolated dissection without any stenoses would be very rare in any kind of vasculitis that I'm familiar with. So that's really what I'm looking for, is where's the stenotic disease? That's what we tend to see with our medium to large vessel patients, right?
Especially any chronicity to it, right?
Yeah.
And often you're right, they're coming in and you don't even know if the dissection was the pain thing that brought them in, because there might be a prodrome of a couple weeks, saying bit of weight loss, pain after eating, which is totally non-specific, whatever.
Might have been gastric.
And I mean, there's case series that they follow celiac artery, some branches of mesenteric, where 50 to 80 or 90% of them have nothing ever again in long follow-ups. And the other 10%, it's weird things like it's around a cancer area or something else that's really not our stuff. Because sometimes we almost get, we're going to make our own decisions, but pushed into please diagnose and treat, because this person keeps going back to emerge or whatever. And the pain sounds like a gallbladder, and this is not the area, right? Sometimes we just have to go back to common sense, but they are tricky, and I'm never satisfied when I treat them. If it's isolated, I agree, you got to look, but I'm not satisfied because I don't think it does anything. And I think I'm treating somebody's worry about an imaging, maybe treating the patient who's worried, but I don't think I think I could be doing more harm than good, so I try not to trigger.
Yeah. I think like segmental arterial medial lysis is maybe one that we've seen where like they keep dissecting. And then people will inevitably turn to us and say like, are you going to do anything for this person keeps dissecting? Are you sure it's Sam? You're like, well, am I sure it's Sam? No. Like, right. So
pathological.
So I think vasculitis in particular, like, does make you work in a pretty gray area where it is a likelihoods game. So you do have to admit that it's conceivable that it's vasculitis. It's conceivable, but I really don't think that it is. Or rather, have I met a treatment threshold? No.
And getting a lifeline. So for people not as experienced, including myself, you get help from an expert. You try to get the radiology guru in an area. So if they're basically the imagers of abdomen or whatever, because they're so subspecialized now, give me the differential. What do you think? Should we repeat imaging down the road? And what are we looking for? I think all that, because I can't do this isolated.
Yeah.
Isolated problem, but I can't function in a vacuum.
Yeah, very much. It does really feel like a team sport, even though it's a blood vessel. Hey, so isn't that like rheumatology? Don't you guys do that? But I think we do need the help. So you found aortitis. You've worked it up. Let's say you've diagnosed TAC or GCA, or burnt out disease. I am very curious. Like, how you and your practice, let's say you have identified that there is aortic involvement, how do you kind of continue to screen, or like what's your long-term screening to make sure that they don't have a big aneurysm 10 years later? Are you doing imaging every year? Do you cut it down to every other year? Do you stop and say, physical exam and clinical follow-up? I'm just curious what your pattern of practice is there. That's a big question. But
Yeah. No, I think this is, again, an area where there's unclear evidence, right? So we sort of do what we feel is right. And it's true. Once I know that somebody has large vessel involvement, okay, so a GCA or attack, I usually would, at least in my mind, think about re-imaging them at least once a year is sort of my lowest common denominator. Now, there are some places maybe where I would re-image sooner if somebody was doing very poorly or if they had clear new findings on exam. So it could be earlier than that. But in the stable, say Takayasu's, 1 year is sort of where I've settled out that would be the longest I would be comfortable not knowing if something was progressing. I think especially in Takayasu's, there are so few other clues to go on. We know that the history is not sufficient. We know that by the time you have a physical exam finding, like an absent pulse, you have almost certainly developed new lesions. And we know that ESR and CRP are definitely not sensitive or specific enough. So I think particularly for the Takayasu's who have many decades of life, I think 1 year re-imaging is sort of my lowest common threshold.
And is that going to be a kind of a lifelong procedure for them, or is there a point at which you're comfortable tapering?
Like 5 years of stability, we'll say. 22-year-old, she's 27 now. She wants to come off some meds. Usually when they ask, they already have. Wants to think about pregnancy and
For the
is on her drugs that maybe are a bit contraindicated in pregnancy. So stable for a long time. So CRP, ESR, normal. Imaging stable, had a really good response in your mind clinically and imaging-wise to treatment.
Yeah.
When do we know it's lifelong? We know it can flare, but when do you kind of say, let's call it quits? Because if I keep giving you CTs, we don't have that much low radiation CT. So cumulative effect of a bunch of CTs in a young woman, at some point we might be doing harm.
Yeah, I agree. Definitely for the Takayasu's, I would prefer MR. Now, at some centers, this is going to be harder to get, including ours. It's hard to get quickly, but usually if with pre-planning, we can arrange for this to be done. But yes, I would definitely prefer MR angiogram in the younger person, certainly. And then after the age of 50, I have sort of come around that CT angiogram is probably a reasonably safe thing to do. I think, and we're talking about can we stop imaging, right? Not can we stop treatment?
Right.
Yeah.
Well, both.
Well,
I mean,
both.
sometimes, but let's stop. Can we stop imaging is probably the first question because they've been stable. Patient seems pretty with it, that she maybe gets a prodrome every time she flares, feels unwell, inflammatory marker goes up. Some of them know, lots of them don't when they're flaring. Big flares they know because they're sick, but little flares they don't know.
I don't know the
Pushing because we don't know either, right?
Yeah, so
Yes.
it depends. So it's true. I've done two things. Many of my patients I do still image every year, and then I can think of one or two where I have it's been so very stable and probably all burnt out even from the get-go that I image every 2, and I think I even pushed one of them to every 3 years, just saying it's been like well over 5 years. We found nothing new. How to make those decisions? I think. At least what I have used is how much damage they have already. Like how much room for error do I have here? Somebody who has quite limited disease, maybe 1 or 2 small vessels with no, significant ischemia. Maybe there's a little bit more wiggle room for error if I get it wrong and something does progress. Where somebody who already has, significant stenosis, 2 or 3 of the arteries going to their brain, that person I am probably going to image every year because there's no real room for error and missing it.
That's such a useful kind of paradigm of what's like the room for error as kind of a
concept, right? I don't know if it will progress. My gut is that it's low, but what if I'm wrong?
Right. And because it would change your treatment. I mean, we get into anecdotal treatment, but there is there's a series of data publications that can be helpful in trying different things. TNFs, interestingly, sometimes more than IL-6, et cetera, but various drugs. The other thing is I try to get people like that, my Takayasu's with obvious stenosis, into either getting a cardiologist or a general internist or myself on my own to say what drugs are going to reduce post-stenotic dilatation. Should they be on now every new diabetic drug known to humankind to kind of help remodel, because the Ozempic kind of drugs seem to be good for atherosclerotic disease and diabetes, even in non-diabetics. If we take it another, go further beyond and looking at our rare conditions that will never have those RCTs, they're the kinds of things I want to know about, because I'm no expert in like what used to just be we gave beta blockers, treat their hypertension on whatever arm had a better blood pressure, and give a beta blocker for better flow after the narrowing so they don't get their aneurysms later. And we don't see a ton of aneurysms, but I still see loads of people, unfortunately, with stenoses.
Definitely me too. I think that's so important. I think they all should have a cardiologist, honestly, the young Takayasu's. We underappreciate their cardiovascular symptoms for sure, especially the ones with like the very proximal aortic root. They often have, coronary osteostenoses.
And just for, I think, vascular health, because anything, even if they're low, well, I'll call them medium risk, all that stuff should be treated. Like we should probably consider them, I totally made up, but like a type 1 diabetic, treat to targets that are really, really strict, because this person in her 20s or 30s has a lot of years to go that can just by flow have damage.
Yeah,
right.
It's complicated.
Like even developing a little bit of atherosclerosis in a carotid artery that's terribly damaged by vasculitis and quite stenotic, you don't have to get 50% lesions to be lymphatic. You need a tiny bit. And so I think that it is a population we probably need kind of some hand-holding from internal medicine or cardiology about like a very aggressive cardiovascular risk management. Yeah, that's a very good point. I think that is actually a great place to leave it. That has been really interesting to kind of hear your kind of your thoughts on investigation and workup and follow-up of large vessel vasculitis. Wondering, is there anything else that you wanted to mention before we wrap?
Yeah, I think we covered a lot of really interesting aspects. And obviously, there's so much more that we don't know. So, I think I agree. Both the Takayasu's and the GCAs, what we really need is more evidence to help us with some of these really challenging areas that we kind of discussed. But yeah, great pleasure being here.
It was our pleasure. Thank you so much for chatting with us.
Yeah, no, it was really fun.
That's it for this episode of Around the Room. For questions, comments, and future episode ideas, email us at info@room.ca or tag the CRA social media accounts. Around the Room is produced by David McGuffin, Dr. Dax Rumsey, and Aaron Stewart. We'd like to give a special thanks to the Communications Committee and the staff of the CRA for their hard work, and of course to Dr. Janet Pope. Our theme music was composed by Aaron Fontwell. If you enjoyed your time with us, please give us a rating and subscribe so you don't miss future episodes. You can also share this podcast with your colleagues and spread the word on social media. I'm Daniel Ennis. Thanks so much for listening.